welcome back to XGate Dental. I'm Emmanuel Kadosh, and we are here to discuss new procedures in the field of dentistry. We will provide interesting new cases to exhibit how doctors use our products to solve complicated dental cases. Don't forget to subscribe and follow to stay up to date, and let's get started. Today we have a bridge with 4 implants that was made a very long time ago. 4-unit bridge on 4 implants with cemented restoration and a PFM bridge. Here we have a problem because we don't have enough space. You don't have enough space for anything. So the question is, what are you gonna do? We have a few different options. Now, the first option is we can have some bone augmentation. We can add implants and we can have a single crown on a single implant, or maybe we will have a 5-unit bridge on 5 implants if we added an implant. But on the other hand, it may be too many implants for a 5-unit bridge. So the question is, what do you want to do in this case when it's a problematic case for restoration of 1 implant? So what we decided for this case is, instead of making a restoration for this tooth with the addition of an implant or addition of a single crown, we'll use the 4 implants that the patient already has, and we'll just change the bridge and add another cantilever tooth for the same bridge. And in the meantime, we will change it from cemented to screw retained restoration. And this way we can add another implant without any bone augmentation and without any difficult procedures. Adding another crown without adding another implant and another difficult bone augmentation. Maybe there's a little bit of space between the crown and the gingiva, so this is the cantilever. The crown is in there for 1 premolar tooth, and that's okay. It won't break because the forces are distributed. The occlusion part, if you don't make it too big, it won't be an issue. So here you can see the abutments that were beneath the bridge. You can see in this abutment residues of cement that were below the gingiva. Now, you don't want to have a lot of cement below the gingiva because it can cause a lot of inflammation. And if it will cause a lot of inflammation, you can have a problem with the implant itself. So in this area, it's very problematic to see the cement because when you take an X-ray of the implant, you don't see the cement in the buccal and in the palatal area. You see it only on the proximal areas because of the angle of the X-ray. So this cement, you can't see with your own eyes and you can't see with the X-ray. You don't know if there was an issue or what the cause of the issue is. You can see it right away when you take out the bridge. So right now you know that there was residue of cement. There was a little bit of plaque retention and there was inflammation. That's the biggest part with the cemented restoration. You need to clean it very, very, very well, and you don't always know if you cleaned enough because it's below the gingiva. You can see it's almost 2 millimeters below the gingiva, so you don't see it at all. You don't know that it's even there. You don't have any instruments to see it. Even when you do an X-ray, you don't see it on the X-ray. So you think that everything is good, but later on you have some issues. When you take a thick layer of cement, you probably have an inaccurate restoration, because if you had a restoration that is accurate enough and it fits the abutment very well, you'll have a minimal layer of cement. In this case, you have a thick layer of cement. That means that you have a pretty big space between the abutment and the crowns. And you have a big space between the abutment and the crowns, in this case when the crown doesn't fit very well. So the doctor or the technician took out from the crown's material and adds more cement. We took off all the abutments, and you can see that in the abutment with the thick layer of cement and the cement that was below the gingiva, you have the biggest amount of bleeding. That means that it was the most inflamed gingiva around this abutment. We placed multi-units, and on top of the multi-units, we placed healing caps for about a week. Here, what we want to show is the fitting of the abutments at the crowns, right? When we had the crowns on the abutments, we had a problem. We saw that the cement was too thick, and here we can see that the filling between the crowns and the abutment wasn't very good and that there was space. So these spaces, the doctor or the technician wanted to close with cement. Some of the cement leaked out and was around the implants and around the abutments. Then you have some inflammation. This is one of the biggest issues with the cemented restoration, because when you have the crowns and they're not fitting very well, with enough cement, you can still have a passive fit. You can fit anything with cemented restoration. It doesn't mean that it fits very well. And then when you have the X-rays, you don't see anything on the X-rays because you cleaned it all of the residue in the proximal area. But as you saw in the buccal area, we had cement. And in here, you can see the bridge. This is a zirconia bridge with the screw retained restoration. So the screw retained restoration, because you screw the bridge after the cementation of the sleeves, you can clean everything up. You can make sure that you don't have any residue of cement and that everything is polished and clean before. Now, due to the implants being very close, you don't have any other option other than placing the sleeves close to one another. So the sleeves will be close. The multi-units are close to one another as well, and we didn't add any implants. We didn't do anything. We just took out the bridge and changed it to another one. Same with the cemented restoration. Now, the only problem there can be is if the bridge will apply pressure on the gingiva. So in this case, if you use multi-units on the level of the gingiva, you won't have any issues because you can clean between the multi-units and you can clean underneath the bridge if you'll make some space between the sleeves. This is one of the premolars. They broke before we took out the bridge, and you can see that the zirconia bridge with the tooth that we've added. This one is the cantilever that's coming instead of the tooth that the patient lost. It's the same size, and you can scan the old bridge and you can have the bridge with the exact same morphology. You don't need to change anything. This is the bridge mounted. We made the tooth that the patient lost a little bit smaller so that it won't break when the forces are applied, and you don't want to have a cantilever or the occlusional surface of the cantilever too big, because when the patient eats, it'll absorb as much pressure as it can and then it could potentially break. So you make the occlusion surface a little bit smaller, and this is why the integrity of the construction will be much better. Here it rests on the gingiva. It's a PMMA bridge, but later on, of course, we'll make it to zirconia, and you can make it from any material that you want. This is the sleeve. We cemented the sleeves into the bridge, and in this case, you can cement them outside of the mouth and you can cement them inside the mouth. You can do this because you have only 4 implants and they're very close to one another. You don't have a bridge with a very big span, so the longer the span of the bridge, the more problematic and the more inaccurate the final restoration will be. So in this case, you can't cement it because it's a very small bridge. It's 4 implants, but they're very close to one another. So in the scanning process, you don't have a lot of deviations. You don't have a lot of inaccuracy. You can see that in the occlusional check, you have contacts on all the crowns, and you can see that all of the sleeves are inside the bridge, and you don't have any problem with the cementation of the sleeves and no cement residue. You can see that we took a little bit of the material between the sleeves, so the patient will have a little bit of space to clean between the implants. Now, you don't want the bridge to apply pressure on the gingiva. You want the patient to be able to clean beneath the bridge to maintain the implants and the bridge and all of the constructions, because if the patient has the ability for good maintenance, the longevity of the implants will be much longer. You can see here that all of the multi-units that we used are on the gingiva line. So a patient has the ability to clean between the multi-units and between the implants, and the bridge won't apply any pressure on the gingiva. Now, because of the lack of interproximal space and because of the proximity between the implants, it can be a problem using D-type because the D-type multi-unit is bigger in diameter as well as in its height. So the patient will have a problem in the maintenance process. We're closing with plastic pins and adding a little bit of composite material for the retention of the pin instead of the screw channel. You can see the plastic pin with the composite. We just apply the composite onto the pin, put it in, cure the line with composite, and remove the top of the pin and polish the top. We may have talked a lot about this case, but it's very simple. All we did here is just taking out, changing the abutments to multi-units, and making a new bridge, and that's it. Thank you everyone that joined in to learn some new and interesting information. Make sure to stay tuned for more, and of course, don't forget to subscribe, like, and follow. Thank you, and see you next time.